Hello, friends, and welcome to episode 289 of Untethered Podcast. This is your host, Hallie Bulkin, and I am excited because we're actually opening doors super soon, October 21st through 25th. We'll be opening doors to the Myo membership. So go to the myomembership.com, add yourself to the waitlist. But before we jump in today, I want to just state that if you haven't listened to the last episode on screening for myofunctional disorders, I highly recommend you take a listen because we went over some key things to be looking for, and that's going to really help you out today. All right, let's dive in. Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Welcome to the Untethered Podcast. I am your host, Hallie Bulkin. I'm a certified myofunctional therapist, feeding specialist, podcaster, business owner, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, airway, tethered oral tissue, and pediatric feeding therapy space. If you're new here, I challenge you to keep an open mind and join my mission to spread this message far and wide. If you've been around since June 2019, thanks for being a loyal listener. As we jump into today's episode, remember to listen with correct oral rest posture. Tongue up, lips closed, teeth apart, breathe through your nose. Let's get started. Okay, friends. So as I mentioned, doors to the Myo membership are opening October 21st through 25th. Get on the wait list at themyomembership.com. For now, I want to go over some key things when it comes to assessing and treating myo and really orofacial myofunctional disorders, OMDs. So when I say myo or OMD, you know what I mean, okay? I'm using it interchangeably. Now, just like any other therapeutic assessment or intervention, we're going to want to take a case history, right? You're going to have an intake form that asks certain things. But what I like to do is I really like to spend time deconstructing that myo evaluation, that orofacial myofunctional evaluation. And here's the cool thing, right? This is something I teach in a couple of places. I teach it both inside the Myo membership. It was the very first training that still is a fantastic training. It's available from July 2020 when we first launched the Myo membership. So you can go back and watch that if you join the membership. If you end up enrolling in the Myo method, like the full Myo course that I offer, it's in there as well. But I wanted to just share that so you can deep dive into this topic if that's what you desire, because I really think it's important to break things down. And before we can do that, I think we need to review the goals of myo. What are we even doing in myo? What are we looking for? Well, we know we want to correct oral rest posture, oral prep phase, oral phase swallow, while eliminating things like drooling or oral noxious habits, right? When we're putting things in our mouth that are not food items, whether that could be thumb sucking, nail biting, chewing on pencils, anything that's happening frequently with great intensity for, a duration of time. Tongue thrusts, tongue forward rest posture or tongue forward posture, during swallowing, open mouth posture, mouth breathing, right? These are some of the things that we're working on when it comes to myo. And so when I say correct oral rest posture, what do I even mean? I mean tongue up, lips closed, teeth apart, breathe through your nose. Okay, that's our little phrase we say. And I'm really excited because we have a big surprise coming soon, something I've been working on with a colleague of mine for a long time. And so stay tuned because we have an announcement that will hopefully be coming. I think I announced it maybe a year ago, and then we just hit pause again. I'm not kidding when I say we've been trying to get this out to the world for 4 years because we started, I think, when she was pregnant with her youngest, and he is now 4. So anyways, stay tuned for that. Okay, so when I say teeth apart, what do I mean by that? There's an argument in the myo space that teeth should maybe be together, gently together, or slightly apart. I was taught that teeth should be slightly apart. There should be this freeway space is what they called it in my initial course I took, where you have between 2 to 3 millimeters between the teeth posteriorly, between your molars, and then about 4 to 6 millimeters anteriorly, between your incisors. If you're not sure what those teeth are, go Google it. It'll show you an image, easiest way to understand. So what do we do, right? If we've done a fast myo screener, like I talked about in the last episode, we look at some of those findings to carry it forward to see what do we want to dive into when it comes to this individual patient, because while we may give you, like in my course and, everything, we may give you an assessment form, a checklist, sample reports, a template to use to write reports, like literally everything you need. You still need to understand why you're doing what you're doing to make sure it truly is individualized and to make sure you're collecting the right information. So the case history is really important. We give you a comprehensive intake form and you're welcome to use it. It really helps you kind of like gather the information you need up front, prepare your evaluation so that you know what to look for in regards to myo, airway, TOTS. Are there questions that you need answered based on some of the information that was or wasn't provided on that intake and in the case history portion of that intake, right? And one of the biggest tips that I can't believe I'm giving away for free on the podcast, because it seems so simple, but it's so mind-blowing to so many, is listen and ask. Listen to what your patient tells you the problem is for them, whether it's a parent of a child or you're working with an adult or an older child or, adolescent. This is going to be so telling, so telling. Like if you take nothing else away from today, listen to your patient. Listen to your patient. You don't know more than them. You are no better than them. You are there for them. They're coming to you because they need help. Put your ego aside. Listen to what they are telling you. And then use your clinical skill set to help them, right? I get so many people coming to me saying, well, they didn't come back after the evaluation, or they didn't start therapy, or they didn't complete therapy. How do you get people to go through therapy? Well, are you listening to your patients? Are you listening to what they're telling you their chief complaint is? Are you listening to what brought them here in the first place? Because you can get them to do a lot of things if you just listen. And so many therapists struggle with this. They are not listening to their patients. They're not. And then I want you to ask. I want you to ask some key questions, okay? And we're not going to obviously go through like an entire evaluation and treatment in a podcast episode right now, but I want you to ask about their sleep. Because a lot of parents will tell you the child's sleep is great. They sleep all night. Great. So do my kids. If I lay in their bed, the younger one without like she currently uses a myo brace just to like hold the expansion she got. She still needs more expansion. So it's not, in my opinion, an expander by any stretch of the imagination. It's keeping her from grinding her teeth. So why is she grinding her teeth without that in her mouth? We should look into that, right? And then from a parent standpoint too, like, great, my kids don't wake me up in the middle of the night. If they wake me up, it's very rare. And I'm like, what's wrong? Like they don't typically come into my bedroom and wake me up. So why are they waking up? Many times children who wake up in the middle of the night may be struggling with an airway issue. If their palate is high and narrow, if they are still sucking their thumb, if they are sleeping with their mouth open, if you can hear them breathing at night, right? Maybe they're not snoring, but you can hear, we shouldn't hear that. Sleep should be silent. Okay. So when a parent says this, even though I always tell you, listen to parents, listen to patients, if they tell you they don't snore, they don't sleep with their mouth open, like don't take this at face value. That's like the one thing that I don't always listen to. I will say, hey, could you snap like a 3-minute video of your child sleeping like an hour after they've fallen asleep and send it to me? I want to see what the child's doing. I want to see what position they're in. I want to see how their head is positioned to their neck, to their shoulders, to their chest. Are they, anyways, there's a lot that we can get into here, but those are just like 2 really big tips I want you to focus on. And then, do they have a history of like noxious oral habits, right? Any respiratory concerns, history of orthodontia, dental work, now or in the past, tethered oral tissues, any concerns there, right? I'm going to gather a lot of this information in the case history. Obviously, we know our intake forms review like what they think their chief complaint is, medical history, family history, dental history, oral habits, feeding history, if anybody else is currently working with the child and who, and so on and so forth, right? But my myo assessment goes through a lot of things, and I'm going to just kind of list off some of what it goes through so you can have a better idea of what it entails. I like to go least to most invasive in terms of what I'm asking a child or a patient to do, because I want them to build rapport with me. And yes, we can do that during the eval. I want them to start trusting me. I want them to be more comfortable. If you go right at their face and in their mouth to just try and get something out of the way, they're going to be on high alert. It's not a good approach. I'm sorry, it's just not. We have got just pretend like you're working with a 2-year-old. Like 2-year-olds make you earn their trust a lot of times. Like some kids will come straight to you, but other kids are going to make you work to earn your trust. And so an adult and an older child may be more reserved and they may not make you work as hard, but you got to earn their trust in the same way. So least to most invasive is super important. Okay. In my course, and even in the training that I do in the Myo membership, I go over like the tools that are needed for the assessment, like what I recommend, like what type of photos to take in the initial assessment. I'm going to look at rest posture. We talked about that already. Nasal mouth, versus mouth breathing. Their airway. Is their nose patent? Like, do they have allergies? Do they present with allergic shiners? Any history of sinusitis? Why can I not say that today? Any concern with their adenoids, tonsils, etc. Right? Their lingual mandibular differentiation. How well are they using their tongue separate from their jaw? Is everything working as one unit? Are we working individually as we should be? Because all children, by the time they're appropriate for a myo eval, should have lingual mandibular dissociation and differentiation. Masseters, like what does their masseter muscle look like? Their masseters, there's 2 of them, like one on each side. Their mentalis muscle, or chin muscle. I'm going to assess their temporomandibular joints. And I'm not assessing the joint directly. I'm really just kind of palpating it to feel what the muscles around it are doing. And do I feel the joint popping at all, right? And sometimes, again, like this is not to diagnose, because diagnosing anything bone related is out of my scope. I'm allowed to diagnose based on muscle, fascia, soft tissue, right? Not the hard tissue bone stuff. So, I might look at dental occlusion, but I'm not going to diagnose dental occlusion. I will make notes. I will refer for onwards. If somebody has given me something from a dentist or orthodontist or oral surgeon or something, I might include that information in my report, but I will be clear of where I got that information from, right? I will look at the hard palate as well, and the veal and the soft palate. What is their lip closure like, right? How well are their lips functioning? Are their lips strong enough to even maintain closure? Is there something else preventing them from maintaining closure if they're not, such as bone, right? Malocclusion maybe, or position of their jaws. Facial symmetry or asymmetry, right? I mentioned tonsils before, but tonsils and even tongue position as it relates to tonsils, and then tongue position just generally on its own. Their gag reflex. Now, these days, we don't typically gag patients. I was taught to in my first myo course I ever took, and I was like, this is so unpleasant. And I'm pretty sure that people know if they have a heightened gag. So like, I just trust, and you're going to see it in a child pretty easily when you're doing other stuff. If it's too far forward in an adult or an older child, I just ask, they know. I'm going to assess tethered oral tissues. And because I'm a speech language pathologist, I can also assess the oral phase swallow, beyond the oral prep. Like in myo, you can look at oral prep and everything leading up to the point of swallowing actually happening. But as soon as that swallow is triggered, that is no longer the scope of a myo eval. That goes into a swallowing eval, and that can only be assessed by a speech language pathologist when you're going beyond that oral phase. And then their speech, because again, I'm an SLP, I'm a speech pathologist, so I can look at that. So I'm not going to go too much further into this just in terms of like how I break everything down, but I wanted to go over like what is looked at in a myo assessment, because I have therapists, I have, non-therapists, I've got people from all over, other colleagues asking like, what are you even looking at in an evaluation? So hopefully this sheds some light, because when we move into assessment, a lot of what we are assessing is going to come out of what our findings were in the evaluation, right? And so we need to know what the child or adult, what that person sitting in front of us is able to do, what their restrictions are, how functional are they? And if function is impacted, what part of their function is impacted? And what is the root cause? Like, what is the root behind that? We know for a child, for example, that may be mouth breathing that has a V-shaped high narrow palate, the tongue doesn't fit up there. So to even work on getting the tongue up there when there isn't space for it doesn't seem appropriate, right? So that might be a referral out to an orthodontist or a dentist who can do earlier expansion on a younger child, or just, expansion at any other point of the life, really. Because we do believe that the tongue shapes the palate. And if it is not up there to shape the palate starts to collapse. And that's where we start to get these more high vaulted, skinny shaped U or V shaped palates. There's all different kinds of palate presentations out there these days. I'm not going to go into all of that again, but it's really, really important to look at and to consider, because if the tongue can't function to do its job, obviously surrounding, anatomical structures are going to be impacted. That shouldn't be that hard to kind of like grasp just in terms of like concept, right? When you start to see it, you start to go, oh, okay, now I get it. All right. So with all that said, right, as I mentioned, the oral prep phase, when we're starting to look at treatment and everything, we need to remember that the oral prep phase is the start of the swallow. Excuse me. We place food in our mouth. It's controlled by our tongue. We moisten that food with saliva to create the bolus, that ball of prepped food in the center of our tongue, right? If you're properly chewing that food, you're going to be able to, like a rotary chew, you're going to be able to form that bolus. You gather on the center of your tongue, as I mentioned, in one cohesive unit. And that's that oral prep part of the oral phase, swallow, okay? The oral prep phase. Then the oral phase evolves into like your tongue shaping into a bowl and holding that bolus against your palate. And then there's this peristaltic motion of the tongue that pushes the bolus back. The back of the tongue drops to allow the swallow to happen. The tongue pushes the bolus back, towards the throat. The swallow is initiated, and that's where myo ends. So that is what we're working on. And if we're struggling with that, if we're struggling at correct oral rest posture and keeping our tongue up in the roof of the mouth, breathing through our nose, keeping our teeth slightly apart with our lips together, if we're struggling with that correct oral rest posture and nasal breathing, and we have some of these other things I mentioned earlier going on, that is what we are working on in the treatment side of the myo picture, okay? So I wanted to go over that. Speech is not myo. An SLP who's doing myo can also address speech at the same time. If there's picky eating, an SLP or an OT can address that at the same time. But in a traditional myo program, those things are not addressed, because what I just mentioned did not include like picky eating, food aversion, dealing with that, or expanding diets and textures and all that fun stuff. Like that requires a license of a feeding therapist. And so sometimes there are feeding things that are pulled into myo, or speech things that might be pulled into myo. But it's really important to kind of understand where the line starts and where the line ends when it comes to assessment and treatment of myofunctional therapy, or orofacial myofunctional disorders, I should say. So as I mentioned, like in my course, I give you a report template, a sample report, common codes that we bill, all that fun stuff. Some of that, like the codes and everything, are also available inside the Myo membership. I also have an entire training on assessing, as I mentioned, inside the Myo membership, along with a separate training on how to make sense of the results, right? We actually assess somebody for you to see. You see me go through an assessment, and then you can also do a self-assessment on yourself, with many of us do when we're going through this for the first time. And then we basically make sense of it, and we create a treatment plan together. And so what I wanted to point out is that you can complete assessments in person or virtually. There are some people who feel very strongly about only doing in-person evals, and I'm here to tell you that the pandemic, it proved to us that we can do myo virtually very successfully. That said, the person that you're working with should be licensed in the state in which you live in, or a country in which you live in. It depends like where you live, if you're inside the US or outside of the US. But I think it's really, really important to understand what you're looking at, and understand, and have done maybe some like in-person assessments first, just so that you understand what you're trying to do virtually. Because to not be able to put your hands on faces, it is a little bit of a disadvantage, but you start to see things visually, and you can also guide an older patient. I say older patient, like a adolescent, even through adulthood. You can guide an adolescent through adult to feel things on their own face and report back to you. And then you also can visualize them doing this, so that, over a virtual appointment, you're able to see what's going on, right? Because it is just not possible for everybody to have in-person everything all the time, right? It's just depending on location, remote locations, and whatnot, and who's available in your area. In the Myo method, I will also add that we do have pediatric virtual and in-person evaluations of both children and adults in each category. for you to watch. So that's really fun because by the end of that, you've seen me do a lot of evaluations. They're all different ages, like 4 years, 6 years, 17, 26, 64. So you get a really good feel for like different evaluations, as I mentioned. And then yeah, clarifying what you're like finding, making sense of it all, and pulling it into this kind of, I don't want to call it a framework, but really understanding what you're doing in treatment, so you understand how to treatment plan. Therapy is most likely going to address something like eliminating oral habits, which is a whole nother conversation for another day, because I know we no longer really do oral habit elimination programs. If you're doing myo properly, the habit typically eliminates itself during the myo program. And if it doesn't, then you can address it towards the back end of the program. But that's, again, another conversation for another day. We're looking at, your tongue resting posture, your lips, the resting posture, is nasal breathing established? If you're a speech pathologist, you might be looking at oral function for speech. You're definitely looking for oral phase bolus prep and that initiation of the swallow, or at least getting to that initiation point if you're not someone who can treat the swallow. And then maybe there's referrals that you make as well, right? Which is, again, a much longer conversation for another day. But I wanted to just mention this because when we are treatment planning, we need to make sure that we're not like working against anything that's going to hinder progress. So I mentioned earlier, like malocclusion, open lip posture, mouth breathing, a sucking habit can also hinder progress. But again, there's ways to address that through the myo program. Drooling, if there's actual like lingual weaknesses or other weaknesses in the oral musculature, if there's oral appliances that might be in the way, resting postures of the lips, the chewing, bolus prep, oral phase swallow, if they're doing excessive cleanup swallows, if they're maybe drinking, is someone drinking from like an open cup, a straw cup, a water bottle, like what are they able to drink from, right? Because we maybe want to work towards some of these things. And is there something that they're doing that's hindering them from doing this? Is there something that's hindering them from collecting their saliva properly and managing that saliva, right? And so on and so forth. So we need to make sure that we're coming at this holistically and trying to figure out the root behind what we're seeing. Okay. There's many different paths from treatment, from referral, to graduation, from starting that assessment to starting therapy to graduating. Right. So I've talked about this in the past. I'm not going to go through like all the different kinds because there could be like literally like dozens of different ways that patients come through and experience a treatment plan. It's not the same for everybody. And that's what I mean when it should be, individualized. Some people might come in and go straight from assessment to myo, or others may need to go be referred to a dentist for an assessment with them. And maybe they need a growth appliance first. Maybe they need a frenectomy, or maybe they come from the dentist to us. They've already had an assessment with them and now they need an assessment with us, but they're still going into a growth appliance, right? And so it's not time yet for myo. Myo will come later. Or maybe they need myo now and we're prepping for a release and they're going to go into an appliance after. I have seen it so many different ways, and truly to individualize the process, there is no like singular right way. Because a lot of people will ask me like, what is the best option? And I can tell you what was best for me, what I wish I had done differently for myself, what I've done for my kids, and what I maybe wish I had done differently for one of them. Like I can tell you these things, but that doesn't mean that it's going to be the right process for everybody else. So that's where it becomes really important to take the right course, to get connected with the right community of myo professionals and colleagues, and get the support that you need, because all of your cases are going to be different, right? So again, in the myo membership, which I mentioned, doors open October 21st through 25th. Get on the myo wait list at themyomembership.com. Little shameless plug there. We do have an incredible community of certified mentors, trained mentors, people who have been doing this for years now, who run office hours, who run our study clubs, who are in there answering questions 24/7 in our private group. Some of them are even doing some of the monthly trainings, but we bring in other specialists as well for those monthly trainings on topics that the community asks for. So there's so much goodness. There's research reviews, like we do 4 per month dating back to June of 2020. So there's just tons of research reviews in there, tons of other materials, as I've shared, a marketing library, business trainings, like so much goodness. So definitely want to hop in there if this is not something that you are familiar with, or if you're just getting into myo, or you're looking to grow your myo skill set or connect with colleagues who are in the myo space. This is the space for you. We are the original myo hangout online, online study club and all that fun stuff. So come hang with us. I look forward to meeting you and seeing you in there. For now, this is Hallie signing off, and we'll chat next week. Thanks for listening to this podcast. If you found value in this episode and want to hear more of these myo tots, airweight, and feeding related episodes, be sure to leave a review on Apple Podcasts and share this episode on your social media platforms. You can access free resources and all I offer at halliebulkin.com, or pop over to @HallieBulkin on Instagram to get all the latest updates.